Good evening friends, welcome to my channel Critical Care Basics, and as you all know we are running ECG tutorials on this channel and this is the 41st ECG tutorial. The topic of today's tutorial is AV blocks part 1. In this tutorial we will discuss about the different definitions of AV blocks, number 1, number 2 about the etiology of AV blocks in general, and then we'll talk specifically about first degree AV block. So let's start. AV blocks part 1. So as we all know, AV blocks are divided into first degree, second degree and third degree AV blocks. First degree AV blocks is not a block proper, but it is delayed conduction, giving rise to what is called as a prolonged PR interval. PR interval is measured from the beginning of P to the beginning of R or beginning of Q. So when this PR interval is more than 5 small squares, then this is called as first degree AV block, right? In second degree AV block, some atrial impulses are not conducted to the ventricles. So this is second degree AV block. You can see PQRST. Here the P is not conducted to the ventricle. Again you can see this PQRST. So when some impulses are not conducted to the ventricle, that is called second degree AV block. That is further divided into Mobitz type 1, which is also called Wenckebach, where there is gradual prolongation of the PR interval followed by a non-conducted P wave and sudden loss of conduction without any prior PR prolongation, that is Mobitz type 2. We'll come to it. And lastly, when no P wave or no atrial impulses are conducted to the ventricles, then this is called as complete AV block or third degree AV block. So these are the definitions of AV block. AV block is defined as a delay or interruption in transmission of impulse from atria to the ventricles due to anatomical or functional impairment in the conduction system. Like we said, first degree AV block is said to be present when the PR interval is more than 200 milliseconds or 5 small squares. When some of the atrial impulses are not conducted to the ventricles, that becomes second degree AV block. And when no atrial impulses connected to the ventricle or conducted to the ventricle, that is third degree AV block or complete AV block. There is also sometimes a terminology used called as high grade AV blocks. These are intermittent atrial conduction to the ventricles with 2 or more consecutive block P waves, but without complete AV block. So this is advanced second degree AV block or Mobitz type 2 AV block, is sometimes also called as high grade AV block. Now AV block can be physiological. That means it can be seen sometimes in a normal individual. Physiologic slowing of cardiac conduction in response to increased parasympathetic nervous system output, for example enhanced vagal tone secondary to athletic training, sleep, pain, carotid sinus massage, or sometimes there could be carotid sinus hypersensitivity syndrome, which can result in slowing of sinus rate and the development of AV conduction delay or disturbances. Usually if physiological AV block is only first degree AV block, or it could be Mobitz type 1, but never Mobitz type 2 AV block. So this is usually a minor type of AV blocks is physiological. While pathophysiologic AV block is usually due to fibrosis or sclerosis of the conducting system. In 50% of AV block, this is due to fibrosis or sclerosis of conducting system. Here there is 2:1 male preponderance, and this is age related. In less than 55 years of age, 11 per 10,000 people will have AV block, while when the age is more than 65, 55 per 10,000 people will have an AV block. There are two diseases, Lennegra and Lev disease, which are which cause sclerosis or fibrosis of the conducting system. Lennegra disease is also called as idiopathic fibrosis of conducting system. During his initial description, Lennegra consistently used the term bilateral bundle blind block or to describe the cardiac injury pattern that leads to AV dissociation. In 97% of these cases, histologically the AV node is normal, right? So Lennegra identified several ECG manifestations. RBBB, LBBB complicated by complete or incomplete AV block. So there is either RBBB or LBBB with incomplete AV block, and masqueraded bundle branch block. We will come to it in the next slide, and complete heart block. So this is what is called as masqueraded AV block. In the limb leads, the pattern is suggestive of left bundle branch block. So there is white QRS, RS R prime pattern in lead 1 and in lead AVL. So this is suggestive of left bundle branch block. While in the chest leads, you see RS R prime pattern and white QRS complex suggestive of a right bundle, deep S waves in V6 suggestive of a right bundle branch block. So in limb leads, it is left bundle branch block, but in chest lead, this is complete right bundle branch block. So this is called as masqueraded block. And this is an example. This is a patient in whom serial ECGs were taken. This is in 1954, 1955 February and 1955 May. In 1954, he was in sinus rhythm. You can see all the QRS are preceded by P wave. In February 55, he had second degree AV block with some P waves not getting conducted to the ventricle, and in May he developed complete heart block. Another disease similar to Lenegre is the Lev disease, which has been used to, this is also referred to as sclerosis of left side of cardiac skeleton. This occurs in older patient more than 70 years of age, such as that associated with calcific involvement of the aortic and the mitral rings. So various conduction abnormalities can result. For example, fibrosis of superior and basal aspect of muscular septum will usually result, this is the most common pattern, results in right bundle branch block with left atriovesicular block. Involvement of the mitral ring or the central fibrous body will cause complete heart block with a narrow QRS. And aortic wall calcification, on the other hand, can invade the bundle of his, cause the right or left bundle branch block or left atriovesicular block. Second to the fibrosis, the most common cause of AV blocks is ischemic heart disease. So 40% of cases of AV blocks are due to ischemic heart disease. Conduction can be disturbed in chronic IHD, ischemic heart disease, or in acute coronary syndrome. 20% patients with acute MI develop some degree of AV blocks. So 1/5 of patients in MI will develop AV block with the likelihood and the severity related to area and the extent of infarction. And with the restoration of perfusion, if it is an acute condition, especially in fever wall MI, with the restoration of the RCA perfusion, usually the block is reversed. But if it is chronic or the damage is already done to the fascicle or the AV node, then the AV block will remain. IVCDs, intraventricular conduction delay, including the bundle or fascicular blocks, occur in 10 to 20% of patients with MI. And you could see left bundle branch block, right bundle branch block, or left anterofascicular blocks. These are the three most common patterns. After fibrosis and ischemic heart disease comes various cardiomyopathies and myocarditis. Cardiomyopathies including hypertrophic obstructive cardiomyopathy, some infiltrative processes like amyloidosis and sarcoidosis, myocarditis like rheumatic fever, Lyme disease, diphtheria, some other viral disorders, SLE, toxoplasmosis, and even COVID-19, bacterial infection like bacterial endocarditis and syphilis. And in myocarditis, the development of AV block is often a bad prognostic sign. Congenital heart diseases, AV block of varying degrees can be associated with a variety of congenital heart diseases. A structural abnormality example, congenitally corrected transposition of great arteries, large primum ASDs, and large AV septal defect, especially AV canal defects. Interestingly, complete heart block may be isolated lesion with no associated structural abnormality. This is a rare condition most commonly associated with neonatal lupus, which results from transplacent passage of antibodies, anti-ROSSA and anti-LASSB from the mother. Lastly, it could be familial. Many may be transmitted as autosomal dominant. The genetic locus at chromosome 19q13 and other chromosome 3p21, where the cardiac sodium channel SCN5A is encoded. So there are various mutations of this sodium channel can cause AV blocks. Miscellaneous but important causes. For example, hyperkalemia, usually when the potassium rises above 6.3, the patient will have AV block. Hyper or hypothyroidism and myxedema or thyrotoxic periodic paralysis can cause AV blocks. Hereditary neuromuscular diseases like myotonic dystrophy, Kearns-Sayre syndrome and Erb's dystrophy. These are rare conditions but can cause AV blocks. Some cardiac tumors, cysts and myocardial bridging and cardiac trauma can cause AV blocks, and rheumatologic diseases including dermatomyositis. So these are the rare causes. Last but not the least, the medications. Most common drugs which cause AV blocks and which are used in clinical practice are the beta blockers and non-dihydropyridine calcium channel blockers like verapamil and less likely diltiazem. Then digoxin can cause all sorts of AV blocks. Adenosine can cause AV blocks, and antiarrhythmic drugs, commonly amiodarone, and even sodium channel blocking drugs like quinidine or procainamide can cause AV blocks. There is something called Brash syndrome. What happens if the patient is on a beta blocker or a calcium channel blocker? The patient has bradycardia. Bradycardia causes decreased renal perfusion due to decreased cardiac output, which causes renal failure. Renal failure causes the accumulation of the beta blockers. Also, renal failure causes hyperkalemia. Hyperkalemia also causes bradycardia, and non-selective beta blockers also cause hyperkalemia. So this is a vicious cycle. Ultimately, the patient lands up in multi-organ dysfunction with shock, bradycardia, renal failure. So this is called as Brash syndrome. This is the acronym for bradycardia, renal failure, AV blockage, shock and hyperkalemia. So whenever you get such a combination, remember to stop beta blockers. Also, the patient with heart diseases may be on ACE inhibitors or ARBs, which also cause renal failure as well as hyperkalemia. So if a cardiac patient is on a beta blocker and ARBs or ACE inhibitors and he develops hyperkalemia and renal failure, always be aware of Brash syndrome. Some cardiac procedures, notably transcatheter aortic wall replacement TAVI can cause AV block, then catheter ablation for arrhythmia, and alcohol septal ablation for hypertrophic obstructive cardiomyopathy. In this procedure, about 8 to 10% patients will develop complete heart block after the procedure. So, having dealt with the etiology or different causes of the AV blocks, let us now focus on the first degree AV block, right? So, first degree AV block is not a block per se, but this is prolonged AV conduction with results in a PR interval of more than 200 milliseconds. As we just discussed, the PR interval is calculated from the beginning of P to the beginning of Q, right? So when this is more than 5 small squares, this is called as first degree AV block, and usually in the first degree AV block, the conduction delay is mostly in the AV node, but rarely in the bundle of hairs or even the Purkinje fibers. Clinical presentation, this is universally benign, so there are no symptoms. No signs or symptoms that are either sensitive or specific to the first degree AV block, right? First degree AV block cannot be detected by history or physical examination alone, so you have to have an ECG. When there is marked first degree AV block, results in atrial contraction immediately following the preceding ventricular contraction. This can give rise to symptoms and signs which are similar to pacemaker syndrome. So this has been called pseudo pacemaker syndrome. This becomes a rare indication in first degree AV block for a pacemaker. So this is how the ECG will look in first degree AV block. In the upper ECG here, you can see the PR interval is quite long. PR interval is more than 300 milliseconds, but here the QRS is narrow. While in the second example, the PR interval also prolonged, but QRS is also wide, right? So this becomes, for example, if this is say lead 1 instead of lead 2, then this becomes left bundle branch block with first degree AV block, that is called as bifascicular block. This in some of these cases, because in such cases the block is usually below the AV node, either in the bundle of hairs or in the Purkinje system. Hence, usually such patient will require a pacemaker. So what do we do if you accidentally happen to find a first degree AV block in the ECG, right? So get a thorough history, look for the medication or recent change in medication, get a blood work, see for electrolytes, potassium, see for the T3, T4, TSH, exclude infiltrative cardiomyopathies. These are the rare conditions, for example, muscular dystrophy or dilated cardiomyopathy. So whenever you see a newly recognized first degree AV block, so please assess the patient's symptoms and findings to rule out these rare but serious conditions. So if the patient has something positive, then you have to diagnose it, pick it up and treat it. Question about the history of heart disease, either congenital or acquired, as well as any recent cardiac procedures. Think about infiltrative cardiac diseases like amyloidosis and sarcoidosis. Again, these are rare, but think about if Lyme disease is endemic, look for any outdoor exposure or tick bites. Management, most of the first degree AV blocks do not require any treatment except the treatment of cause if something is found. For example, patient has hyperkalemia, treat hyperkalemia, or patient has hypothyroidism, treat hypothyroidism. So only rarely is pacemaker required in first degree AV block. Like we discussed, when the atrial contraction occurs immediately following the preceding ventricular contraction due to severe AV conduction delay, then symptoms and signs similar to pacemaker syndrome occur, what is called as pseudo pacemaker syndrome. This sometimes requires a pacemaker. When there is first degree AV block with concurrent neuromuscular diseases like rare diseases like myotonic muscular dystrophy, Kearns-Sayre syndrome or Erb's dystrophy, then such patient will require a pacemaker. When patient has a wide QRS complex in conjunction with prolongation of PR intervals, what is called as a bifascicular block, which implies a significant possibility of conduction delay below the AV node. So sometimes these patients require a pacemaker. Thanks a lot for being with me in this lecture. If you are liking this lecture, please like, share and subscribe. In the next lecture, we will discuss about Mobitz type 1 or Wenckebach block. Thank you so much.